Hi everyone, my name is Darcy Cherlin and I am from George Washington University at the Milken School of Public Health. I study global health epidemiology and disease control. So today I'll be talking to you about my research project, an evaluation of the referral pathways at the breast cancer screening clinic at Ocean Road Cancer Institute in Dar es Salaam, Tanzania. So globally, breast cancer is the most common cancer in women. It has the highest incidence in high-income countries, but the lowest survival rates in low-middle-income countries. And that can be attributed to late detection programs, late-stage diagnosis, and lack of adequate diagnosis and treatment facilities. In Tanzania, breast cancer is the second most common cancer after cervical cancer, and 80% of women are diagnosed with breast cancer in advanced stages. A study was done in Tanzania specifically looking at the causes of this and attributed them to late detection, late diagnosis, and late treatment process. Tanzania does not currently have a national screening program for breast cancer. They do, however, have 5 sites that claim to have early detection programs, one of which is Ocean Road Cancer Institute, which is in Dar es Salaam. So the overall goal of this project is to look into why we're still seeing late-stage diagnosis of breast cancer by evaluating the breast cancer referral pathways for screening, diagnosis, and treatment at the early detection program at Ocean Road Cancer Institute. This project has 3 specific aims. The first is to determine the proportion of patients who receive recommended testing. The second is to look at the proportion of patients who start treatment after going through the pathway. And the third is to assess specific variables and to see if they attribute to barriers to receiving the recommended diagnostic testing. So the first thing I needed to do was understand the aspects of the early detection program, what the pathways consisted of, and how patients moved through those pathways. So the pathways consist of 3 different sites. The one end of ORCI is the breast cancer screening clinic, then there's Muhimbili National Hospital, and the treatment side of Ocean Road Cancer Institute. This diagram shows how patients move through the referral pathways. So a patient comes in and she is immediately screened for breast cancer by a nurse. If she has abnormal findings, she'll be screened by a physician. If the physician suggests, if the clinical breast exam is suggestive of cancer, they'll be referred for an ultrasound or fine needle aspiration. If they're not suggestive of cancer, and they're over the age of 40, they'll be referred for a mammogram. If any of these tests are abnormal, they'll be referred to Muhimbili for a HPE or surgical evaluation, and if they're diagnosed with cancer, they'll be referred back to ORCI for treatment. So the methodology involved in this study was to first establish a cohort that we could follow through the whole pathway. So in order to do this, I used the EMR at Ocean Road Cancer Institute, and with the help of some of my fellow IT colleagues there, I was able to export a report that gave us all of the patients screened in 2018. So there were 3,993 patients screened in 2018. I then sorted through all 3,993 records and split these patients into 2 groups. One group was our inclusion criteria, so our cohort. This consisted of 680 patients, and these patients were patients who were referred for further diagnostic testing, and the other group were patients who were not referred, so they either had a normal breast exam or an abnormal exam, but were treated with medications and sent home. I also looked at a subset cohort, which were patients referred to Muhimbili to follow patients to see if they returned for treatment. So the data sources that were utilized to collect the results, the dates of the results, and the types of referrals was the EMR mainly, but also pathology files and the paper records at both ORCI and Muhimbili. So here's some demographics of my cohort. You'll see that most of the patients were between the ages of 20 and 50 years old. 98.5% were female, 80.3% lived in Dar es Salaam, and 75.9% were symptomatic. 6.8% of the cohort were ultimately diagnosed with cancer, and 69.6% were in late stages. So some preliminary findings. About 50% of the patients who were referred for testing received those tests, had results present in the data that I reviewed. You'll see if you look at each individual test that the mammogram is slightly lower than 50% at 33.6%, and the FNAC is slightly higher at 67.4%. The last column shows the percentage of patients who there were no results present for. This either means that the patients did not receive the recommended testing, they received the recommended testing at a different location and it did not come back to ORCI, or they did receive the recommended testing but the results were not uploaded into the system at ORCI. On the right is a box plot which shows the duration from the initial referral to the received tests. So you'll see that the last box plot is the HPE evaluation, which is what we would expect this to have the longest, take the longest number of days. But we also see a wide variation in the other tests, which tell us that some patients are taking just as long as going through all the way through the pathway to a histopathological evaluation to get a mammogram or an FNAC, to get those initial tests. So for the second aim of our study, we wanted to look at how patients moved from the diagnostic side of ORCI to the back to the treatment side, going through Muhimbili. A limitation of this study was we did not know who was referred. We did not necessarily know where patients were referred for testing, but with working with my in-country mentor, we were able to identify 60 patients who were referred to Muhimbili based on their results of their FNAC. So I followed these 60 patients, and 20 of these patients did return to ORCI for treatment, so that's 33.3%. And then we wanted to know what happened to the other 40 patients. So we were able to go to Muhimbili and see if those patients had indeed been seen there. 19 of those patients were not in the Muhimbili records. 8 patients were diagnosed with cancer but did not receive treatment at ORCI. 2 were not diagnosed with cancer. 4 were completing the testing process still, so they were waiting for their tumor board appointments. 2 were terminally ill and were still waiting on 5 of the patients in that cohort. So the box plot on the right shows intervals of, or the time duration of each part of this pathway. And so the first box plot, which is in the dark blue, shows the duration of initial referral to the FNAC results. The second is the FNAC results to the start of treatment. So that includes going to Muhimbili, getting your HPE evaluation, and then coming back to treatment. And the third is the initial referral to the start of treatment. So that's the time it takes to complete the whole pathway. Now what you'll see is that the median of the FNAC results to the start of treatment at ORCI is only a little bit lower than the duration of the entire pathway. So that really shows us that if there was a place to put in an intervention to decrease the time of diagnosis and the start of treatment, it would be in this time interval from when a patient's referred to Muhimbili and comes back to start treatment. So some preliminary conclusions to highlight: 50% of patients were referred for testing did not have results in the available data, and of the 60 patients referred to Muhimbili for an HPE, only 20 returned to ORCI to start treatment. So implications from these preliminary results are there are significant amounts of incomplete pathways for patients receiving breast cancer testing and treatment. So future analysis, I'll be conducting a statistical analysis to look at the association of age, region of residence, tribe, insurance status, and education between the two. I'll separate the cohort into 2 groups, so those who received testing and those who did not receive testing. And then I'll also look at those who started treatment versus those who did not start treatment. And finally, I'd like to do a spatial analysis to look at the districts in Dar es Salaam and to see if there were certain districts that we're seeing more patients receiving results from. So future research and action. So from this project, just from the preliminary findings, we can identify a group of patients that have not received their recommended testing, and that data has been shared with ORCI, and they can utilize that to follow up with those patients if they so choose. The methodology of this study can also be used for a patient navigation program. So if ORCA wanted to, they could take this methodology and turn it into a procedure. Patients, or someone who is hired at ORCI would audit these patients every 3 to 4 months and then follow them through the pathway to see if they received the recommended testing. And then for future SEEP students, I think a lot of the next step involve interviewing these patients to get more information on where they went, or why they did not receive testing, why they did receive testing, where they went for testing, and then the comprehension of instructions and why they were receiving that testing. They can also interview physicians and hospitals to see how many patients from ORCI they receive for diagnostic testing, and then if it is in their protocol, to send patients back to ORCI after diagnostic testing. So some strengths and limitations of the research site. It was an extremely welcoming community and staff. I felt very supported as I began my research there. The electronic medical record is fairly new at ORCI and a great resource. It really helped me sift through those almost 4,000 records multiple times. The in-house pathology lab is also fairly new, and this made it really easy for me to just walk over to the lab and start pulling the records that I needed. Finally, it was pretty easy to understand how ORCI worked, understand the pathways and procedures, and get started with my research. So some limitations and recommendations. There's not currently a procedure to document where patients are referred or the precise date of testing, so we could create one could create a space in the EMR to do so for tracking purposes. As a student, I did not have access to Muhimbili to go myself, but if future students wanted to use the Muhimbili records, I would recommend that they try to obtain access beforehand. The pathology lab documentation. So right now it's currently decentralized. Pathology labs results are in one location, and then there's the EMR, and each patient's test results are in individual Word files. So I think it would be really great to centralize those documents in the EMR to help with research and further tracking of patients. And then I would just recommend overall more frequent meetings with in-country advisors. I know every time we met, it was extremely productive. I got insights that I didn't have, and I think doing these on a weekly basis to talk about our preliminary results, if possible, I know everyone's busy, would really contribute to the research. Learning experience. This was an enriching cross-cultural experience. I learned all about Tanzania culture, dress. I'm wearing a dress made from Tanzania right now. Learned about the food and history of Tanzania. I also learned a lot about early detection programs in low and middle income countries and the differences of their utilization in the United States, then in the United States. And then finally, community engagement. My colleagues and I had the opportunity to talk to several groups of students at ORCI about our research in breast cancer and learn from them as well, and I found this extremely rewarding. So my future plans include finishing my master's, mentoring future SEEP students, and once graduated, my future career goals involve working for a hospital, government, or healthcare system to do work similar to this, to look at health systems and evaluate access to care and how we can improve access to care and make those pathways more efficient. Finally, I'd just like to thank my mentors, Dr. Solomon and Dr. Masami, as well as Dr. Musalagi and the rest of the ORCI and Muhimbili staff, my colleagues, Zoe, Lindsay, and Shanjita, and then previous SEEP students who helped me prior to going to Tanzania. Thank you very much. Questions? Yes.
What is your... Thanks. That was a really excellent presentation. I was wondering what your hypothesis is with respect to a spatial analysis.
Yeah, absolutely. So one would, with respect to the spatial analysis, I would hypothesize that the areas closer to Dar es Salaam, or to the ORCI, are going to have, we're going to see patients having received those test results more than the patients who did not, who live farther away, mainly because they have to come back and forth or travel to different locations to get those tests, and if they have to travel long distances, they're less likely to do so.